Okay, the topic today is assessment of a patient in shock by echocardiography. Well, shock has been defined as a life-threatening generalized maldistribution of blood flow resulting in failure to deliver and utilize adequate amounts of oxygen leading to tissue dysoxia. Now, importantly, the presence of hypotension is not required to define shock. Although hemodynamic instability is most frequently present in development of shock, clinical signs of tissue hypoperfusion and biological markers of inadequate tissue perfusion, like decreased central venous oxygen saturation or mixed venous oxygen saturation, increased blood lactate, increased base deficit, and a low pH can be observed even in absence of hypotension. This is the triad of shock where decreased systemic vascular resistance, which needs vasopressor therapy, then hypovolemia, which requires fluid repletion, and heart failure, univentricular or biventricular dysfunction requiring inotropic support. Now, this is a generalized algorithm illustrating successive steps using echocardiography for assessment of a patient in shock. First step is to assess whether there is fluid responsiveness. And if there is fluid responsiveness, one should go for fluid loading. If it's not, then one should look for cardiac failure, for evidence of cardiac failure. When these two are ruled out, the vasopressor is the treatment of choice. And in presence of cardiac failure, we have to decide whether it's LV or RV at fault and treat accordingly with inotropes or vasopressor. In echocardiographic signs of hypovolemic shock, like a small left ventricular end-diastolic area, small left ventricular end-diastolic diameter with less than 2.5 centimeter, end-systolic obliteration of LV cavity, normal IVC diameter with collapsibility. Now, there are certain dynamic circulatory indices, respiratory variations of vena cava diameters and aortic Doppler velocities, which have been validated in such situations to assess the fluid responsiveness. Now, peak aortic velocity variation of 12% or more in both adults and children predicts fluid responsiveness. The central venous pressure can be gauged by assessing the inferior vena cava and its collapsibility, where a dilated vena cava with little collapsibility means that the central venous pressure is in the range of 10 to 20 with a mean of 15, and a normal sized IVC which is collapsible more than 50% means the normal range of 0 to 5 with a mean of 3. And outside these two paradigms, any other situation, the diameter is, the CVP is in the intermediate range of 5 to 10 with a mean of 8. So in a patient without spontaneous inspiratory effort, that is a patient on mechanical ventilation, the IVC is actually dilates during inspiration and collapses during expiration. So this distensibility index of IVC, and the reverse occurs in case of SVC. But the distensibility index of IVC predict fluid responsiveness with a cutoff value of 18%, and that of SVC, the collapsibility index of SVC predicts fluid responsiveness with a cutoff value of 36%. So in order to measure the cardiac output, we usually measure the stroke volume, which can be gauged by the aortic VTI. And since the alveolar diameter, the area remains constant, so alveolar VTI gives a fair idea about the stroke volume. And in case of aortic VTI in normal adults, the value is 20 plus minus 3 centimeter. And the fluid responsiveness is by definition an increase in cardiac output, generally by more than 15% after adequate volume challenge. And the passive leg raising test, which mobilizes about 300 ml of blood from lower extremities to intrathoracic compartment, reproduces the effects of fluid volume expansion. So this is the estimation, the imaging of LVOT VTI, which shows a clear increase after a fluid volume, after fluid challenge of 250 ml. And this is a respiratory variation of aortic velocity. In absence of preload dependence, as we said earlier, the second stage is to ascertain whether there is any cardiac failure or when both significant hypovolemia and cardiac failure has been excluded by echocardiography, vasopressor therapy needs to be considered. In case of septic shock, there can be a profound cardiovascular alteration using decrease in vascular tone, hypovolemia, or myocardial depression. So it should be assessed step-by-step fashion by echocardiography. So the following aspects, the cardiac output by measuring the aortic VTI and heart rate, and the fluid responsiveness to be assessed by the aortic flow or the vena cava diameters and collapsibility, ejection fraction, and RV function. Actually, from the clinical point of view, in case of septic shock, the objective of echocardiography is not only to assess the systolic function of LV, but to assess how the heart responds to the change in load situation. For example, a low ejection fraction can reflect either an intrinsic systolic dysfunction or an excessive LV afterload induced by excessive doses of NORAD. Or conversely, a normal ejection fraction can be observed in a patient with intrinsic left ventricular systolic dysfunction when the LV afterload is markedly diminished. In this situation, inotropic drug infusion will never improve the hemodynamics and should not be implemented, actually. Now, in case of severe unvarious function, if there is concomitant LV dysfunction, then the choice is dobutamine, whereas in case of RV dysfunction where the LV function is preserved, the choice is NORAD. This is also another important point. And in patients with septic shock, special care should be taken to rule out endocarditis, since these patients with septic shock may present with bacteremia or fungemia, and the cautious inspection of valves should always be performed during echocardiographic examination. So along with echocardiography, the parameters which should be noted are the central venous oxygen saturation, lactate, base deficit, and central venous pressure to note whether the preload can be effectively increased during a fluid challenge. Now we are coming to acute circulatory failure with pulmonary venous congestion. In this case, we have to first see whether there is LV systolic dysfunction. If there is no LV systolic dysfunction and in presence of LV volume overload, we will look for causes like acute valvular regurgitation or processes dysfunction. If there is cardiogenic shock, one has to see whether there is any myocardial infarction and or any of its mechanical complications. And in case of non-ischemic pathologies like non-ischemic cardiomyopathy, myocarditis, myocardial contusion, etc. Now, a situation can occur where there can be a precipitation of acute dynamic alveolar obstruction in a patient with shock. And this is primarily seen in elderly patients who present with anterior wall myocardial infarction. The obstruction develops as a result of compensatory hyperdynamic function of the anteroseptal and inferolateral walls. And similarly, it can be present in ICU patients with inotropic therapy who are already volume depleted, and also seen in Takotsubo or stress-induced cardiomyopathy. Now, acute myocardial infarction accounts for the majority of cardiogenic shock patients, and here we're coming straight away to the cases. The first case of acute MI, where the LED territory is severely hypokinetic to akinetic. We'll next move on to the complications on MI, free wall rupture leading to a huge pseudoaneurysm. And here there is severe MR, acute severe MR due to ruptured papillary muscle, and we can see the head of the papillary muscle. Ventricular septal rupture leading to an acute VSD. And next we're coming to non-ischemic causes like myocarditis, severe LV dysfunction. This is a case of COVID myocarditis. Now, next, valvular pathologies like acute AR produced by aortic valve vegetation, the dilated IVC, severe AR, increased LV filling pressure, the high PASP. In a case of LV dysfunction, in a case of aortic stenosis, low flow, low gradient aortic stenosis and cardiogenic shock. Now we are coming to the circulatory failure with systemic venous congestion. Straight away we can rule out cardiac tamponade by echocardiography, and then RV dysfunction or dilatation. If it's present, then whether there is any pulmonary hypertension or not. If there is no pulmonary hypertension, and that's usually seen in a RV infarct, whereas the presence of pulmonary hypertension points towards pathologies like massive pulmonary embolism, ARTS, decompensated biventricular systolic dysfunction, in end-stage cardiomyopathy, decompensated chronic or pulmonary, etc. And this is the case of RV infarct. This is inferior wall infarct in the basal part, and this is the RV infarct, the TAPSE of 4.3. So right ventricular infarction is a unique type of coronary syndrome where increasing RV preload with fluids is of vital importance. And the paradox of raising already raised RV EDP and right atrial pressure is often a challenging task. Now, the one rule of thumb is an increase in IVC diameter by 30% from its basal value would be a cutoff for point for termination of fluid infusion. And this is a huge thrombus occupying the RARV. It's coming from the inferior vena cava. Another case of a huge thrombus in pulmonary artery with severe RV systolic dysfunction. Next, we are coming to pericardial tamponade, where echocardiographic features of acute pericardial tamponade like RV diastolic collapse and RV systolic collapse of duration more than 1/3 of systole, reciprocal respiratory variation in RV and LV inflow velocities, and IVC plethora. This is a clip of a pericardial tamponade. We can see the RV diastolic collapse. So more than 40% variation in tricuspid inflow velocity, or more than 25% variation in mitral inflow velocity in case of pericardial tamponade, the IVC plethora. Now, this is an interesting case of cardiogenic shock, where we can see a normally functioning heart. And this is the same heart after orthoptic cardiac transplantation. And the body of here after transplantation, there's significant RV dysfunction. The dilated IVC. RV dysfunction is an immediate post-cardiac transplant period has been described, and which needs to be aggressively treated. Otherwise, it may progress to overt failure. To sum up, in a nutshell, I mean, the clinical syndrome of shock, along with the echocardiographic findings and leading to intervention, when there is severe hypovolemia, hyperdynamic, we find the findings of hyperdynamic function, small LVEDA, small diameter IVC with collapsibility, requiring volume depletion. Then distributic shock with euvolemia, where there is hyperdynamic function with normal LV and diastolic area and normal IVC, NORAD to support the mean arterial pressure is the intervention. And there is left ventricular failure with global left ventricular systolic dysfunction or significant RWMA. It requires inotropic support with dobutamine or epinephrine. And in case of RV failure, with as a result of acute pulmonary embolism, acute core pulmonally dilated or hypokinetic RV as a finding with decreased TAPSE, increased RV basal diameter, flattened D-shaped intraventricular septum. Here, if there is pulmonary embolus, it warrants anticoagulation or thrombolysis. And in case of shock, it should be treated with inotropic support with dobutamine or epinephrine. So with that, we come to the conclusion of this presentation. Thank you.